I wanted to talk a little bit about the public health paradigm and traditional public health systems and how we can potentially rethink it, particularly how we interact and are intersectional in thinking about immigration and race. So the public health system, I know we're not all part of the public health system or the traditional public health system, and although I think most of us have learned quite a bit about public health over the last months, but it's a very complex system from federal, tribal, state, local, municipal, county government systems that all work together, usually very well and sometimes not so well. But there are occasionally some very competing priorities as well. So today I wanted to talk about sort of what the traditional paradigm of public health has been and where there might be some opportunities to shift the paradigm and think anew. I'm going to talk about three particular areas: workforce and systems, service delivery, and then the narrative itself. I know everybody's been in conversation about and interested in talking about COVID. I want to talk a little bit just briefly about COVID here in New Hampshire and our response. And then I'd like to think about what is this new narrative that we can build together. On the screen is a picture of my grandmother. This was taken of her when she was a young woman in British occupied Palestine. At this time that this picture was taken, she had no idea that she would have a family of her own that she would have to shepherd out of her home into many other different homes, and a very long and winding route to come to the United States as a refugee and live here as an immigrant and build a life in Boston. So I put her picture up because I think it's important to remind ourselves, and always to remind myself, that when we talk about immigrant families, we're talking about real people with real experiences, varied experiences, but all important to understand. So I always like to honor her, and I also like to honor the colleagues and the people who came before me, whose shoulders I stand on to talk to you today. So just briefly, I wanted to touch on this concept of upstream, downstream in public health, because I do talk about it a little bit throughout the presentation. So when I reference upstream, I'm really talking about these very systemic and institutional societal inequities that exist in racism, classism, in discrimination and gender discrimination. And then when we talk about downstream, we move a little further down and we tend to talk about issues like disease and injury and mortality. And this has become increasingly apparent, I think, as in the conversations around COVID and the pandemic. So first, I wanted to talk a little bit about workforce and systems in public health, the traditional paradigm, the dominant paradigm, and where the opportunities exist. And of course, public health systems are everywhere on the continuum of this. Some have moved further along, some have not. So the traditional public health paradigm in workforce and systems is that the public health system sort of holds the core of knowledge around how to do good service delivery, and they function as the core safety net. And they do talk about disparity and functions of disparity, but it's often really focused on as a downstream issue, and we're certainly seeing that now around the issue of COVID. And like many systems, the core traditional public health, government public health systems don't reflect the diversity of the communities that we serve. Particularly, this is true in the areas of leadership. Of course, Denzel shared with us, and it's true, that if you broaden your concept of public health, as I think we should, then we begin to see that there's a much more robust representation of people from many different communities present. So the first point of opportunity is to think about the public health system as an expansion to include clinical services, social services, everything from arts, media, academics, industry. It's really a multi-sector, a whole health approach to public health. And in that system, we would ideally begin to see disparity really discussed as a result of upstream systemic issues. And so that those upstream issues begin to get as much or more attention as the downstream issues. And of course, in the workforce, we strive and would like to see a more diversified workforce, including leadership positions, maybe most especially leadership positions. But of course, diversifying your workforce alone doesn't meet the need. So organizations, of course, need to seek to actively engage in learning about equity, what equity means, and how to build more equitable organizations. In service delivery, the traditional public health paradigm has really been that service is informed and driven by funding availability, traditional data collection resources, and maybe some information around national need. The information that goes out from public health systems, the messaging is often available in dominant language only, or significantly, and in very traditional mediums. And the information about how to serve communities in need, including immigrant communities, is typically created within traditional public health systems by public health professionals, or sometimes in collaboration with academic institutions, but it rarely has a community participation or voice component. And so the opportunities for shifting that paradigm exist. Many of them exist. And ideally, just to move through them quickly, communication access becomes the norm. It's well done, it's available, it's accessible. Bicultural and bilingual staff are present. You can see this working well in community health representative and community health worker models. The historical and cultural mores about health and wellness that exist across culture are understood, respected, and very appreciated. That public health activities, core public health activities like evaluation and resource allocation are meant to ensure that systems are working for all and not just some, or not just the majority, but all. And if they're not working for all, that we're identifying where those gaps exist so we can meet the need. And lastly, an opportunity for paradigm shift exists in thinking about the incredible knowledge that immigrant and other communities hold about the impact of strong social support systems and this deep historical understanding of what the social determinants of health really are and how they impact community. This knowledge can be leveraged to increase the public's health at large and to increase the public health knowledge base. But it has to be done with special attention to citing, crediting, and compensating immigrant communities that lend their knowledge, their labor, and their authentic voice. Lastly, I want to talk about the narrative itself. So the traditional paradigm in public health has always been data tells the tale. And in public health, data is really the language that we speak. And when we talk about immigrant communities, communities of color, marginalized communities, we often talk about a deficit-based narrative. Talk from the perspective of a deficit-based narrative. And so what I mean by that is we talk about disparity, we talk about inequity, and those are not untrue narratives. However, it's one side of the story only. We often find too that stories are told of and for immigrant communities and other communities of concern, but they're not told by. And we find that we focus on sort of our success. What we call our success is the form of outputs, outcomes, very measurable data sets. And I think there's a lot of opportunity for shifting the narrative paradigm here. And that would be that when we talk about disparities, when we talk about inequities, when we focus on what might be more deficit-based narratives, that there should be the inclusion of the also strength-based narrative as well, because we know those of us who come from immigrant communities or refugee communities or other communities that have been marginalized, that there is a tremendous amount of strength there that can be talked about. So where are the community assets? What are they? What is the body of knowledge that immigrant and other communities hold? Because for every deficit, there is a strength to be told as well. I'd also like to shift some attention to thinking about capturing ethically and equitably capturing first-person narratives, allowing immigrants and other communities to tell their own stories and to own those stories, to choose where and when they share them, but it's their voice and it's an authentic voice. So we'd also like to see that our success adds in, so our measurable success sort of begins to include thinking about building authentic relationships between persons and between systems, because that's where the trust exists that allows us to do good work for a long time. And again, focus some more attention on the upstream issues. And that does require us to actively and openly talk about systemic and institutional racism, historical oppression and trauma, its impact on communities of concern, including immigrant communities.